Welcome to Caring for Patients with Nasal Polyps in 2023, When to Consider a Biologic or Surgery, presented by the Global Education Group in collaboration with the Asthma and Allergy Foundation of America and broadcast simultaneously in Immunology Live and Res Insights Live. This is the fourth module in the four-part series and is titled Treatment Pathways for Nasal Polyps. My name is Dr. Stella Lee, and I'm a director of the Brigham Sinus Center at Brigham and Women's Hospital. Today's session is interactive, allowing us to take your questions in real time throughout the presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. Katie Buchheit, Associate Physician at Brigham and Women's Hospital and Assistant Professor at Harvard Medical School. Thank you, Katie, for joining me today. Let's get started. These are our disclosures. These are our learning objectives for the series. We will summarize the burden of disease and treatment for patients with nasal polyps with a focus on outcomes that matter most to patients, such as the ability to smell, sleep, and be productive. Describe the type 2 inflammatory relationships between nasal polyps and common comorbidities such as asthma and aspirin sensitivity, AERD, or NSAID hypersensitivity, or NERD. Explain how enhanced knowledge of nasal polyp endotypes and type 2 inflammatory pathways can guide treatment decisions. And finally, review recent recommendations for the management of nasal polyps with surgery and or monoclonal antibody therapy, especially as they apply to the management of uncontrolled severe nasal polyps. This is Module 4, Treatment Pathways for Nasal Polyps. So let's first talk a little bit about nasal polyp management. As we know, this is a quality of life condition, and so CRS management is really based on symptoms and how severe they are, the presence or absence of whether polyps are there, and presence or absence of comorbidities such as asthma, allergies, and AERD. Yet there are limited validated biomarkers to guide treatment decisions, and so as of now, we have some goals that we really would like to achieve for our patients with nasal polyps. As you can see here, ideally, polyps should decrease in size as we treat our patients with medical therapy or with surgery. Patients should have relief of their symptoms. Their quality of life should improve. We should really try to avoid recurrence if possible and manage the comorbid conditions that can impact patients' quality of life. Currently, there are multiple new guidelines for management of CRS with nasal polyps, and let's get into it. So the International Consensus in Allergy and Rhinology published an evidence-based management of CRS. And as you can see here, some of the recommended guidelines on the top middle, that patients with all chronic rhinosinusitis are recommended to undergo saline irrigations that are high volume and also low pressure. Corticosteroid irrigations can be also helpful. And especially patients with nasal polyps, intranasal corticosteroids, there are many different ways to apply the topical steroids to the paranasal sinus lining. There are irrigations with corticosteroids, atomization, nebulization, and oral corticosteroids. We really do try to avoid prescribing those if at all possible. The short-term treatment may be necessary in certain patients. In patients with AERD, aspirin desensitization is also another option. And you can see here the duration of the trial. And on the left-hand side of the screen, you can see that after appropriate medical therapy, that surgery might be considered, as well as perhaps biologic therapy, especially if there's failure with medical or surgical treatments. These are some of the treatments that are not recommended, as you can see in the middle column here. And there are definitely areas where we are still doing research to understand whether topical antibiotic therapy can be helpful. There is some evidence to suggest that certain antibiotics, such as non-macrolide therapies, can be helpful in patients who have nasal polyps. But again, there's still more research needed in this area. And on the far right side of the screen are different treatments where patients often do treat themselves, and there are a lot of over-the-counter medications these days, but there's insufficient evidence to really recommend many of these things that are readily available to patients over the counter. This is a nice NIH workshop review that looks at the indications for biologic therapy in patients with CRSwNP. And the conclusion from this group was that first, if medical management fails, including these treatments, as you can see here, including management of comorbid conditions, and if they do not improve with surgical intervention, that perhaps additional medical therapy can be considered, but also perhaps at that time, revision surgery or biologic therapies can be considered. And they also discussed that it is important to look at sinusitis symptoms, whether it's with the patient-reported outcome measures, as we have discussed, lower airway symptoms, medication need, especially for oral corticosteroids, and the endoscopic evaluation, especially if patients have recurrence and severe nasal polyps. This is a multidisciplinary expert panel that was convened and published in 2021, showing that initial management of CRS with nasal polyps starts first with a different topical nasal steroids, especially there are many that are over the counter now, but there are now also more advanced and enhanced treatments with topical steroids, including the exhalational delivery systems, as well as steroid-eluting implants. So these can be done either in the office, and some steroid-eluting implants are actually placed in the OR. So there are other trials and research underway looking at different ways to apply topical anti-inflammatory medications directly to the sinonasal mucosal lining. Other things that are important to assess include different comorbid conditions, including for allergic rhinitis, AERD, and as we mentioned before, for potential granulomatous disorders or vasculitis, and then escalation of treatment if necessary. And as you can see here, the recommendation from this multidisciplinary expert panel was on whether surgery will be recommended or when biologic therapy would be considered. And the conclusion was that in the majority of patients, sinus surgery would be expected and that it should be offered. And the extent of surgery should be discussed because some patients might require more extensive procedure than patients who might not have as extensive obstruction or disease. And postoperative management should be discussed, including the need for irrigations, topical intranasal corticosteroids, or enhanced delivery of corticosteroids. And as we talked about in a prior module, because patients who have CRS with NP have high rates of recurrence and persistent inflammation at times, despite our best efforts with surgery and extensive surgery and oral steroids and topical steroids, that there are these new treatment options that we have available to us. And it really is a shared decision-making process with the patient that all of these different options should be offered, and the pros and cons of each option should be discussed in detail. And assessment is also important. There are differences in time periods of when patients should be followed, but this panel recommended about 6 months. And if patients have persistent disease, obviously if patients are really symptomatic and, at 2 months or 3 months, they're really not happy and really symptomatic, then it would make sense to see them earlier. But regular and close follow-up for these patients is important. Coaching for different topical therapies that are done at home is important. And the minority patients, they recommended if they are not cleared or too frail to have surgery, they have really poorly controlled asthma, or really, and especially patients who are dependent on oral corticosteroids, or patients who really do not want to have surgery. I think that's also really important to point out. When you have informed consent, it's really important to outline all of the options available to patients so that a really good decision can be made between the doctor and the patient. And also missing here, I think, though, is also that multidisciplinary approach, especially when you have such amazing colleagues like Dr. Buchheit, who's here with me, to make that decision together in a multidisciplinary panel. And we are moving more towards those kinds of conferences where we discuss complex patients before we make a recommendation that's hopefully all in agreement to the patient. And then the biologics that are currently available to us, dupilumab, omalizumab, and mepolizumab for the treatment of CRS with NP. The European position on the management of chronic rhinosinusitis is also really important, which is here in the EPOS 2020 statement. I want to point out, I think a lot of these types of treatments are similar, and there are some differences in how the European position statement looks at antibiotic therapy. They're definitely much more conservative on the recommendation on antibiotics at all, that there really is no great evidence on antibiotics for CRS. But you can download some of these slides after this presentation because there's a lot of information here. One thing I did want to point out was that the presence of alarm symptoms, especially if the patients have orbital symptoms or unilateral disease, is really important to think about something else that could be like a tumor or other lesion that is not a necessarily diffuse CRS with nasal polyposis that should be treated appropriately. And this is another a continuation of that schematic that shows that when you have diffuse bilateral CRS, you want to follow the management scheme as we had discussed. But if there is localized or unilateral disease, that definitely we should think about other processes that are occurring that might have a different differential diagnosis completely. And so that needs to be considered. This is the management scheme for diffuse chronic rhinosinusitis, and I think this is a nice way to look at type 2 versus non-type 2. We are moving more towards not just categorizing patients to polyps or no polyps or CRS without NP, but based on inflammatory endotype, which is nice. And so you can see here, there are some recommendations for type 2 inflammatory disease, which is a bit different from patients who have non-type 2 disease. But in general, appropriate medical therapy, including functional endoscopic sinus surgery, are options for both subsets of patients, and close follow-up, assessing whether patients have improved on the decision making and the actual treatment that was eventually provided is really important. Again, alarm symptoms. And there are subsets of patients who have allergic fungal rhinosinusitis depending on the geography. So those patients also have a different potential endotype and treatment options available to them. EPOS 2020 also came out with a assessment of control, which is a different, which is a new part of our language and our vocabulary now, and we are trying to get to better tools for assessing inflammatory control, similar to what is done in the lower airways. There are some tools out there, but they are not widely used. So this is a nice way of looking at how patients could be assessed by the physician. So controlled, partly controlled, or uncontrolled, and you can see the different symptoms as well as endoscopic findings or the need for rescue therapy on the left-hand side. Again, it is also important not only to have physician assess control, but to ask the patients too whether they think that their disease is controlled. And if you do incorporate the patient input, it does make the assessment more accurate. This is a new update to the EPOS Euphoria criteria for biologic treatment in CRS with NP, and a bit of a continuation and similar from what was published in 2020. The only difference really is that blood eosinophils, the limit was lowered a bit to 150. But in general, you can see that the criteria are here, the evidence that the patients have type 2 inflammation, that they may need, that they have been treated or have needed systemic corticosteroids. And you can see the cutoff points here, greater or equal to 2 courses per year, or long-term low-dose steroids significantly impair quality of life. You can see that they are using the SNOT-22 cutoff of 40, significant loss of smell, and comorbid conditions such as asthma. So I will turn this over now to Dr. Buchheit to talk about the biologics currently approved for CRS with NP.
Great. Thank you so much, Dr. Lee. So as you led us through, there are now all kinds of guidelines that sort of help to dictate when we would use a biologic for chronic rhinosinusitis with nasal polyps. There are 3 biologics that are currently approved in the United States for treatment of chronic rhinosinusitis with nasal polyps. Dupilumab, which is targets interleukin-4 receptor alpha and blocks IL-4 and IL-13 signaling. Omalizumab, which targets IgE, and mepolizumab, which targets IL-5. Really importantly, when we think about comorbidities that our patients with nasal polyps have, all 3 of these biologics are approved for other indications. So oftentimes when you have a patient with nasal polyps who has a comorbidity where one of these biologics would be efficacious as well, we will choose that. So dupilumab is approved for atopic dermatitis. It's approved for patients with moderate to severe eosinophilic asthma, eosinophilic esophagitis, and now prurigo nodularis. Omalizumab is also approved for atopic asthma and chronic urticaria. So if I have a patient with nasal polyps and chronic urticaria, I might consider that as an option. And mepolizumab is approved for severe eosinophilic asthma, hypereosinophilic syndromes, and then EGPA as well. So really, it's useful to know about your patient's comorbidities when selecting a biologic. Dupilumab is administered by an injection at home, whereas omalizumab and mepolizumab can be administered at home or in the office. Importantly, omalizumab does have a black box warning for anaphylaxis, so we recommend the first 3 injections be given in the office. The dose is 300 milligrams every 2 weeks for dupilumab and 100 milligrams every 4 weeks for mepolizumab. For omalizumab, the dose depends on the patient's weight and their serum IgE level, so that is something that you need to measure before starting it. And we'll talk in a minute about side effects, but in general, all of these medications are very well tolerated with minimal side effects. Important to know that both dupilumab and mepolizumab have very limited safety data for pregnancy. Omalizumab has more long-term data. It's been approved for long time for asthma, so there is some reassuring registry data about its use in pregnancy, but we don't typically initiate therapy during pregnancy. So looking at the primary endpoints from the phase 3 studies of all the currently available biologics, there are some similarities in the way that these studies were done and analyzed. There's also some important differences, and really important to understand is there have been no head-to-head studies comparing any of these biologic agents at this point. On the left, we see the studies from the dupilumab This is from the Sinus 52 study. There were actually 2 phase 3 studies done, Sinus 24 and Sinus 52, that were similar in some ways and had some important differences. What I want to point out here is that after 52 weeks of treatment, patients who received dupilumab in the blue and gray bars compared to the patients who received placebo in the purple bars had, on average, a reduction in nasal polyp score of about 2 points out of 8, so shrinkage of the nasal polyps. And really importantly, these patients felt quite a bit better. They reported decreased nasal congestion compared to the patients on placebo. For the phase 3 studies for omalizumab, they're called Polyp 1 and Polyp 2. We see some similarities. Treatment with omalizumab also decreased the nasal polyp score by about 1 point on average at 24 weeks. And it also decreased patients' reported nasal congestion. In the phase 3 study for mepolizumab, Synapse, this data is presented slightly differently in their phase 3 study, but we see that a certain percentage of patients had improvement in their nasal polyp score, so reduction in the nasal polyp size on mepolizumab treatment versus placebo in blue. So the mepolizumab treatment is peach and placebo is blue. And we see that patients who were treated with mepolizumab, some had reduction in their nasal polyp size and also reported improvement in nasal congestion as well compared to placebo. In terms of safety findings for biologics for treatment of nasal polyps, I had alluded to this a little bit earlier. These drugs are actually really remarkably well tolerated by many patients. For dupilumab specifically, the most common side effect that we often see are injection site reactions, so redness and irritation at the site of the injection, which can often be managed. In the nasal polyp studies, they did see very few patients with conjunctivitis. That's a more common side effect in patients who have atopic dermatitis, but something that we occasionally see in patients with nasal polyps with dupilumab. Arthralgias have been reported. And then really rarely gastritis, insomnia. Peripheral blood eosinophilia is seen in patients with nasal polyps, also patients with asthma. So that's something to be aware of and let the patient know about. And then toothache was rarely reported. In terms of, for omalizumab, in terms of important safety findings, again, quite well tolerated with really very few differences between omalizumab and placebo. But important things to call out are upper abdominal pain, injection site reactions, arthralgias, also headache and dizziness was reported. And there is the black box warning that we talked about for anaphylaxis, which again is very rare, especially in patients with nasal polyps. And then lastly, on the right, we see safety data from the Synapse study for mepolizumab, which again is really very safe and well tolerated. There's a few kind of overlaps, upper abdominal pain, arthralgias were reported, rash, nasal dryness, a few other things to be aware of, but generally these are quite well tolerated. So as I mentioned earlier, there have been no head-to-head studies comparing any of the available agents for treatment of nasal polyposis. However, there are some indirect treatment comparisons, and this is actually a visual abstract from, or graphical abstract from a network meta-analysis of 29 randomized controlled trials looking at efficacy of biologics for nasal polyps that actually included about 3,500 individuals with 9 different treatments, looking at a variety of really important outcomes, including patient quality of life, symptoms, smell, need for systemic steroids, need for surgery, and adverse events. And this is a useful way, I think, to look at the currently available biologics, dupilumab, omalizumab, mepolizumab, and some potential differences. Again, there are certainly limitations to this type of study. It is not replacing a head-to-head trial, but we see in the outcomes that they measured that dupilumab was rated as among the most beneficial in 7 of the categories, and really no difference from placebo in terms of adverse events. Omalizumab was rated among the most beneficial in terms of health-related quality of life and symptoms, and then intermediate benefit for 3 other categories. And mepolizumab was rated among the most beneficial for symptoms, but intermediate benefit or no difference for placebo in terms of adverse effects and adverse events. So, based on this, we think that, there is clinical benefit for all of the currently approved biological therapies, but dupilumab, certainly is among the most beneficial in a variety of categories. So I am going to hand it back to you, Dr. Lee, to talk a little bit about how we monitor the response to biologics.
Great, Katie. Thanks for that review. So when we are trying to decide on surgery versus biologic therapy, I think it's important to obviously be aware of all of the different endotypes, but also the comorbid conditions, as we've discussed. And this table pretty much says very bluntly that we can't predict a response today. So there's no biomarker currently that tells us a patient should go the biologic route or the surgical route, or maybe both. But we can at least do a couple of things, which are these little check marks. We should first confirm the patient has uncontrolled and severe CRSwNP, check for the comorbid conditions, check that type 2 inflammation is probably present, and that the patient should be fully informed of these different options that are now available, and then including surgery too, the pros and cons of surgery as well as biologic therapy. And then the selection of biologics is another topic altogether, and that also it's so important to understand the mechanisms and the data that Dr. Buchheit just presented in order to make those decisions wisely. And then finally, that collaboration with someone like Dr. Buchheit is so important, and have that multidisciplinary collaboration is tremendously helpful. This schematic talks about the follow-up for patients. This is one of the earlier Euphoria papers published in 2021. There's still there's an agreement that after 6 months of treatment, that we should assess some of these factors, such as whether patients are able to smell, whether their congestion is better, whether their polyps potentially are better, whether their quality of life is improved, and if not, then it would make sense to reevaluate and reassess the patient and have another discussion about what other options are available, and perhaps change course. If the patient is improved and the improvement is acceptable to the patient, then you would continue the biologic therapy. But if it's not, then perhaps salvage surgery, perhaps a short course systemic corticosteroids, although we really try to avoid that. And then at a year, similar types of assessments, and again, a constant reevaluation, whether patients are doing well, or whether there needs to be another option or other options discussed. This is an update of that 2021 document, and this was just published this year. And it does go over similar criteria, including the need to see a reduction in the polyp size, the reduced need for systemic corticosteroids, the quality of life improvements, the smell improvements, the improvement in the comorbid conditions. And then they have an interesting way of categorizing criteria. So good means that you meet 4 to 5 criteria of those listed on the left. Poor, as you can see, are only 1 to 3 criteria met, and no response is 0. So then again, evaluation after 6 months, and again after a year. But evaluation over time. Some patients may need to be seen more frequently, but likely probably no longer than 6 months is what the recommendations are here. And the way to really grade nasal polyps, the point made here is it's really still a bit controversial, and so that is an area that needs further research. These are some unmet needs in CRS with nasal polyps that we're still working on. And the shortcomings, as you can see here on the left, that still there really aren't, multidisciplinary centers. And when I meet with my colleagues across the world and even in the US, there still is a need for more of a dialogue between care providers, between surgeons and between otolaryngologists and allergists, immunologists, pulmonary doctors, sometimes even rheumatology. So we can do better for our patients by having kind of that multidisciplinary coordination. The management, or even, as I mentioned, the diagnosis of the comorbid conditions is important, and we still need to work on that. There's health inequalities, not only within the EU, but definitely here in the US. We need more education amongst our physicians and our trainees. We need to personalize the care. We need to make sure that patients are involved in the decision-making process and really understand what the options are to them. And many patients still don't really know what, when I first encounter a patient who has polyps, it's a bit of a longer discussion than the patient even anticipates, because it's a discussion about the potential etiologies of what polyps are, that it's a chronic inflammatory disease, that there is no current cure for it. And that discussion hasn't been really conducted. And it does take some time to go over all of those things with the patient. The burden of disease and control of disease, still, we need to understand how to assess that better and how to assess the concept of control. And access is always an option, a barrier to patients and also to physicians as we go through lots of paperwork to make sure that patients get the treatments that we think are best. And so there are some suggestions here. This is from the European perspective, but I think they do apply also to our patients here in the US too. So in summary, CRS represents a heterogeneous spectrum of inflammatory diseases. The current standard of care treatment is a bit limited. We have saline rinses and topical steroids and enhanced delivery of topical steroids and more advanced surgical therapies, but there is recurrence of polyps and still a need to understand the underlying mechanisms of disease. And so as of now, we do have a better understanding of what type 2 inflammation means, including IL-4, IL-5, IL-13, IgE, TSLP, et cetera. But we still need to understand how all of these in conjunction work together and how patients' inflammation changes over time and by geography and with different genetic variations. So a lot more needs to be done from research, also with biomarker development, or at least finding and perhaps developing a biomarker that can be helpful for us to prognosticate patient outcomes and personalize that treatment. So we will move on to our Q&A session.
Yeah, great. So it looks like there's some questions coming in. We just have a few minutes. But the first one I think is a great question, and one that I'll direct to you, Stella, which is, do you predict that biologics will at some point replace many endoscopic sinus surgeries?
That's a common question that a lot of otolaryngologists have on their minds. I think it's great that we have more options for our patients now, and whether it will completely replace surgery, I think perhaps a better way to think about it is, how will the introduction of newer treatment options that are really advanced change the way we think about the disease and how we better manage our patients? So in the future, I do see it happening already, I'm sure you do too, is that patients now have more choices. And I think that's a great thing, that we can even use biologics in conjunction with surgery. So there are different ways to approach patient management strategies. It's all of these pathways that we mentioned in this module. There is really need for more evidence for these pathways, but ultimately, really, you think about how different the disease is in each patient, and perhaps a cookie cutter approach it's not going to work, and so we really do need to understand the patient over time, and the endotype of the patient, the comorbid conditions of the patient preferences, and all those things. And from that, I think we can be better physicians, and our patients will be happier too. But I don't, thinking about whether one thing will replace another treatment modality. It's possible, but I think for now it's nice to have multiple options.
Yeah, no, I would agree with that. And, when I meet patients, clearly I can't offer surgery, but I refer, most of my patients have a discussion with my ENT colleagues. There are many patients who do really well with endoscopic sinus surgery. And I think that should not be overlooked. And we really, we need to work on identifying, in advance, ideally someday, the patients who will not do well. But, certainly I think that the very long-term risks are really well established for sinus surgery. And so offering that to especially young patients who've never had surgery, I think is really, really important. I think we have time for maybe just one more question. Which actually, this is something that I'm really interested in. If a patient does not respond to the initial biologic they're treated with, should they be switched to an alternative biologic? So this is a really excellent question, and something that we are learning a lot about as we go. We published a study several years ago in looking specifically at switching therapy in our patients with AERD who had really severe nasal polyps with often severe asthma necessitating treatment with biologic therapy. And we had many patients with AERD who were treated with anti-IL-5 or IL-5 receptor targeting biologic for asthma, but had persistent sinonasal symptoms. And for those patients, many of them elected to switch over to dupilumab targeting IL-4 receptor alpha. And we actually saw in that scenario, switching from the anti-IL-5 or the anti-IL-5 receptor alpha, patients who had inadequate control of sinus symptoms did benefit from treatment with the anti-IL-4 receptor. So I think there are certain scenarios where there is, I think, somewhat limited but useful evidence to support switching therapies. We have a lot less data about switching from an anti-IL-4 to an anti-IgE or anti-IL-5 receptor. So that is something that we're learning about, which patients, again, identifying biomarkers or other predictive factors that will help us to really personalize treatment for patients would be ideal in the future, and something that I think everyone is very interested in doing.
I was curious, that was a great overview. I was curious about aspirin desensitization. Do you find that now that you're doing less desensitization, or patients are electing not to do it? When do you find that that treatment is still appropriate or has its place in the treatment algorithm?
Yeah, no, this is a great question. So again, there's very limited evidence to kind of guide this at this point. But what we're often doing is, for a patient who's never had surgery, like, a good quality surgery with aspirin desensitization, we are offering that as really a therapy for them to choose from. And, given the very well-known, long-term, well-established side effects of aspirin, some patients, want to go with something where we have a lot of long-term data. So we are certainly offering it to patients who've never done that before. And patients who've previously tried and failed surgery plus aspirin desensitization, we are often offering those patients biologic therapy rather than revision surgery and repeat aspirin desensitization. And then there are patients with AERD who really have other reasons why they would also benefit from aspirin desensitization and daily aspirin therapy, such as they are cross-desensitized to other NSAIDs, so they can take them for pain, or patients who have a cardiovascular or cerebrovascular indication to take aspirin, we're desensitizing them as well. So, it is certainly very individualized to the patient based on their comorbidities, their history, their asthma control, and their personal preferences.
Thank you, Katie, and thanks to our audience for the great questions. I'd also like to thank Regeneron Pharmaceuticals and Sanofi for the support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com and resinsightslive.com to view today's session, along with other sessions on demand. My name is Dr. Stella Lee. Thank you so much for joining us.